This week on the BackTable podcast.
There's so much changing every day. And so for me, how I oftentimes get data is after a big meeting like ASCO or ASCO GI or ASCO GU, we have disease state specialists in our practice that then send out the major practice changing updates from those meetings to the entire practice so that we know, okay, here's the data that's changed and specifically what's changing practice, because that's what I really care about. I don't care about some phase 1 trial that just reported data and like maybe that's going to move into a phase 3 trial. I want to know, okay, how do I need to treat my patients different today than a month ago? And so oftentimes, again, it's coming from colleagues sending out updates to our practice, at least for me personally.
Dr. Baker, how's it going?
It's good. How are you?
Good. Is today an admin day for you? Is that right?
Today is my administrative day, my sole administrative day.
Well, thanks for taking a little time. So I'll get right into it and I'll ask you, because you're relatively like fresh out of training, right?
Correct. 2 years as of September.
2 years in September. Okay, cool. Perfect. So I'll start by asking, was there a big transition for you in terms of like, okay, now I'm out of training and now I'm in practice, as far as like what your day looked like, how you approach patient care, what was that transition like for you?
Yeah, I think it's a pretty big transition because you're going from having all of this like protected learning time as a fellow to then just going out into the world and seeing patients and trying to be, as busy as possible seeing patients. And so that transition, I think, can be very difficult. I felt very prepared by my training program specifically to go out into the real world. I think because we had a clinic as fellows where we were personally managing our own patients, and it was a fairly busy clinic at a VA. And so that I felt prepared me pretty well to go out and do general oncology practice because it was not very different from what the patients that I was seeing and the vibe of the clinic during my training. And so clinically, that felt fairly easy. I don't think that it always feels that way for others, especially if you're in a training program where you're primarily shadowing or working with attendings rather than seeing your own patients, if that makes sense.
You got thrown into the fire a little bit earlier than maybe some people do. And
exactly.
That was a better training program.
Well, I think it depends on what you're doing with your career,
not better,
right?
But that equipped you.
It really did equip me for community oncology, where I'm seeing lots of different types of patients. I'm sometimes managing in resource-poor communities. And so like that environment at the VA where I was doing something very similar prepared me really well for what I'm now doing in clinical practice. But I think there are academic jobs where you have a lot of resources, you're only seeing one type of patient, where like I wouldn't have necessarily needed that experience to be able to succeed clinically.
Seeing one type of patient means what?
Yeah, good question. Meaning like one disease state. So only GU cancers or only GI cancers, for example, whereas I see all types of cancer and not only cancer, but also benign hematology and malignant hematology.
I've talked to a number of surgical subspecialists who, I'll get into kind of whether they're doing a new procedure that they maybe didn't do in training or doing a procedure they haven't done since training, or they only do once every few months or something like that. For you being an oncologist, like what's the analog of that, if there is that analog?
No, I think there is totally that analog. So lots of rare disease types that you may not have seen during fellowship that you have to figure out how to treat. Especially within malignant hematology, there's so much variability within malignant hematology, and it's really an art. And while there are NCCN, National Comprehensive Cancer Network guidelines, patients don't always fall into that classic textbook presentation. And so there's a lot of nuance into how you're treating patients in the community. And I may not have seen that exact patient with this exact diagnosis in fellowship. And I think that it's very similar to how the procedural specialists are.
I mean, you said there's a lot of nuance into kind of like the patient, disease states, but I'm guessing also what's different than, say, a surgical subspecialist is that your treatment is much more collaborative with your patient.
It's very collaborative. And I think that is one of the challenges coming out of fellowship, that like figuring out how to have those discussions and like nuancing that to the specific patient that's in front of you. Because some patients want all the data. And oncology is a space where there is a lot of data. So I have patients coming in that are like, I want to know the 3 options that I have, and I want to know what the survival data is for each. And sometimes we don't have all of that data. It can be difficult to have all of that right in front of you, especially in a busy clinic. And so it's figuring out how to use tools to help get the data that patients want. But then also, like, some patients just want to be told what they should do. And so then you just have to sort of read the room and figure out what each patient needs.
So let's get into that, actually. I mean, how does it work in practice? Like, okay, so let's just pick a cancer type, and now let's say there's a new treatment available and there are guidelines for this treatment. Let's pretend that's true. So now you have patients maybe asking about it, and even for the patients that don't ask about it, you're thinking about it. Like, how might you have learned about this treatment? Is it like everybody in oncology knows about it? Or you just like showed up at ASCO and you heard about it? Or like, how do these things make their ways to you?
It's a really good question. And I think it's variable between like somebody like myself, a community oncologist, versus somebody that's only treating GU or GI or lung cancers. So for me, I think the breadth of data is so much, I could not keep up with it by myself. It's just impossible. There's so much changing every day. And so for me, how I oftentimes get data is after a big meeting like ASCO or ASCO GI or ASCO GU, we have disease state specialists in our practice that then send out the major practice changing updates from those meetings to the entire practice so that we know, okay, here's the data that's changed and specifically what's changing practice, because that's what I really care about. I don't care about some phase 1 trial that just reported data and like maybe that's going to move into a phase 3 trial. I want to know, okay, how do I need to treat my patients different today than a month ago? And so oftentimes, again, it's coming from colleagues sending out updates to our practice, at least for me personally.
What does it take for something to be practice changing for you?
Typically, that's something that has published data that shows an improved overall survival or progression-free survival. Typically is how it starts in medical oncology. It can be tough to get that long-term overall survival data. That's often not being reported out for several years. So we'll oftentimes use progression-free survival as an interim measure, and then the overall survival data will be reported out later.
Is that bar the same for everybody? Like what they consider to be changing practice, or does everybody have a different standard?
I would say that's pretty uniform across oncology. Yeah.
Okay. I mean, and there's some that are like, well, that's not good enough. Like I need to also hear, I don't know, X, Y, and Z. Like,
Yeah.
I hear Kate's doing it or something.
Yeah. I mean, I think there are some people that are going to be early adopters. I would say I'm probably on the early adopter side of things, probably because I'm close to being out of training and I'm used to using new therapies and I'm used to seeing the data all the time. And then that's generally also my personality. And some people are going to want to see some real world practice with these drugs, especially within oncology. Like some people are going to want to see their colleagues have a few reps with the drug and understand how to make dose adjustments, for example, things that aren't included in the clinical trial, because that is sort of the nuance of oncology.
And so I guess you have disease state specialists in your practice who are sending you like, hey, all right, guys, this is what we need to know about this type of cancer, and this is what's new, and this is how we should change our practice. And I guess that's based on the data, like you said. What else do you need to know?
Well, let me give you an example, because I think that's like going to be helpful. So recently there was Destiny Breast 05 data that showed that in early stage HER2 positive breast cancer for patients with high risk breast cancer, so, typically multiple lymph nodes positive or large tumors that did not have a complete response after neoadjuvant therapy, so chemotherapy and HER2-targeted therapy that's given before surgery. So people that did not have a complete response and had very high-risk disease benefited from getting a different drug in trastuzumab deruxtecan versus a drug called Kadcyla or TDM1 that we were giving before for those people. So I recently had a patient who, like right after this data came out, presented to me. She had had upfront chemotherapy and HER2-directed therapy, did not have a complete pathologic response, had nodes positive even at the time of surgery. And so we had a nuanced discussion about, okay, this is new data. All I have is progression-free survival data. It looks really promising. I don't have overall survival data. There are risks associated with this therapy compared to the other one that we used to use. So for TDXD, there's a real risk of pneumonitis or interstitial lung disease. So patients can have potentially really bad lung complications. And so the things that I needed to know was, okay, what is the benefit over this other drug? And the progression-free survival data for that specific trial was like pretty significant. So like, what is the benefit is one thing I like to know. And then the other is like, what are the risks or downsides with this therapy compared to the other one? So always counseling patients about, potential side effects or potential long-term risks is the other thing that I'm thinking about. And so it's a little bit of a nuanced conversation, especially with new data. And to find that data, I'm typically like then pulling up the trial and figuring out like, okay, because they'll usually publish that side effect data. And obviously the progression-free survival data will be presented as well.
What if the patient doesn't fully fit the scenario? Like they don't fit the guidelines or the data and you're like, okay, how do I what do you do then?
Yeah. Then I'm running it by colleagues, typically via tumor boards or running it by my specific disease state experts. So I just have a group of people that I'm very comfortable reaching out to. That was something that you just have to like put away your pride and know that you're doing the best thing for your patient if you're asking for help. And everybody needs help at some point. Like you aren't practicing good medicine if you're not asking for it.
Well, because the answers aren't clear. It's not like there's always a clear-cut answer. I mean, there's a lot of different ways to handle all of these.
Correct.
This is kind of a broad question, but just like help me understand, is it common for other community oncologists like yourself to have those resources?
I would say I'm in a pretty resource-rich practice. So Tennessee Oncology is pretty large. We have over 100 medical oncologists. We have surgeons and radiation oncologists within our practice. We have a large clinical trial arm. And so we're probably the third largest community oncology practice in the country. So we're pretty resource rich. I would say in smaller practices, that's probably going to be more difficult. But I imagine that there are still it's all still a community, right? So even sometimes I'm going to my colleagues at academic centers if it's a particularly difficult case or a rare diagnosis or something that I don't think our internal teams would be able to give me guidance on. Like, I think for the smaller practices, there are other ways to get that same kind of collaboration.
So let me ask you kind of a weird question here. Like, let's pretend I'm a marketer at I don't know, making it up, Lilly or something. Okay. And obviously I don't know about this patient you're treating, but let's just say I did. I'd be like, oh, well, actually there's this information that, your disease state specialist didn't know, but there is this new there's this data or other information related to this specific scenario that I think you would find relevant. Now, maybe that scenario never actually happens. You're like, no, that's not how, no, my disease state specialist tells me what I need to know, so maybe that's the answer. But the question was going to be, how would that information make its way to you? Do you consume, webinars of some kind or other bits? What else makes its way to you?
I think oncology is a little bit unique in that the physicians, at least in my practice, there's pretty regular contact with MSLs at meetings, In other scenarios, we have educational programs with them. So I don't really feel like there's a gap in the information, in getting information from like pharma, for example.
Right. And that's the job of the MSL, is to kind of propagate that information to physician thought leaders, as an example, and be like, all right, Dr. Baker, let's meet at ASCO and let me share with you what's new. And you take that meeting and you learn what's new if it's directed, if it's relevant to you. It could be said when you're training, like, okay, there's so much information out there, I could never possibly know all the things I need to know, versus like, all right, well, there's a lot of information, but I know what I need to know, to practice effectively. In the context, I guess, is, medical information is, it's expanding so rapidly, especially in oncology, and lots of places. It's impossible to keep up, actually. But, sometimes you feel differently about how much you have to keep up, but I'm also curious how you do keep up generally, if that makes sense.
Yeah, no, that makes sense. You can easily get overwhelmed by the amount of information, particularly in oncology, that's out there and you need to know. But I think it's about drilling down to like what you actually need to know to be an effective clinician, right? So I said earlier, what I really care about is practice changing data. I'm not going to know about all of the data that's being presented at ASCO. That's just impossible. All I need to know about are the 9 plenary talks or whatever. So I think it's just about remembering that, I'm not a researcher, so I don't need to know all of that to take care of my patient in the day-to-day. I think the physicians that are also researchers need to keep their thumb on the pulse of that a little bit more, but they also typically have more protected time to be able to do that.
Yeah. I guess just last question, what should I have asked about that I didn't, related to this topic? Or what else comes to mind for you, if anything?
Yeah. I mean, the other thing that I'll say about just being an early career physician and especially somebody that's also in an administrative role, I think it's really helpful to just say yes to things sometimes in your early career, just so you can get a little bit more of a handle as to what's going on with research, what's going on with the administrative folks. That has less to do with clinical care, but more so I think has just helped me to elevate my role on the administrative side of things and just better understand how a practice runs. Because I think especially within community oncology, that's important. There are a lot of docs that don't really know the things that impact our patients day to day at the regulatory or legislative level. And I feel really lucky to be in a practice that supported me exploring those passions.
Well, it's great that you get to do that. That's awesome. That covers it for me. Kate, thanks for taking the time. I appreciate it, and our audience appreciates it.
Awesome. Thanks, Anish.
All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a BackTable hoodie in your future. If you have questions or comments, DM us. We're @_BackTableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.